who is the patient. But the truth is, we are all potential patients. I remember the other time I was telling someone that a B is not just about sexual relationship. You can go to your dentist and somebody could have gone there, and if the right measures are not being taken, you leave and then bam, you contracted. We those always in the operating theater, we know all the risks involved. And so is with Hep C. We shouldn't think that the patient is just the person who has it, but at least the patient knows that he has it. What of us? We don't know when we will contract it. So it is good we all put our efforts, knowing that whatever we do is not just for the patient, it's for we ourselves, as we are all potential patients. One of the things we want to deploy when it comes to these diseases includes the free primary health care, where we think that we should integrate this into the rest of our programs so that the home visits and the outreach services that we'll be conducting will make sure that we talk about these diseases. We'll make provision for the test kits to be available to establish the diagnosis, and we'll make sure that we have the vaccines for those who will require it. And so we are working hard, but we can only achieve if you support us, because we will not be on the ground everywhere. It's you who will be on the ground. It's you who will do the diagnosis. It's you who will establish the treatment, and it's you who is the face of the service, the face of the ministry, and the face of the people and the government. So I just want to say thank you so very much to each one of you for coming online and knowing that whatever we do, we are doing for our own selves, for our families, and for the next generation of our children and our country. Thank you, everybody. And we look forward to active participation, great questions like last week. And should there be any need for further assistance, we are always available. And especially to the program manager, Dr. Duboka, who has taken this to another level. And that has come to consolidate my stance when I was first trying to bring a gastroenterologist into the program to spearhead it. One thing is about quality, it's about the level and understanding of the person. And there's no better person than a gastroenterologist to talk of hepatitis to us. So, Dr. Duboka, you have our support 100%, and we look forward to a country free of these diseases by 2030 as is being prescribed. Thank you, everybody, and let's have a good session. God bless us all. Chairman, over to you.
Thank you very much, Gigi. And so I think now we'll hand over to the moderator to guide us through the session. Thank you.
Thank you very much, DG, and thank you very much, Dr. Asiedu Pekwin, for your remarks and for ushering us into what we are going to have for today. So, a few housekeeping rules before we start the actual presentations. You may please leave your questions in the Q&A session so that they can be answered. Please do well to keep your mics muted during the presentation so we can have a smooth presentation as well. And afterwards, we'll have some time for questions. Our first speaker is Dr. Yvonne Nati. She's a gastroenterology fellow in training with a strong passion for liver diseases, particularly viral hepatitis. And has numerous research projects in her BNC regarding her work here in Ghana. And these have continued to advance research and improve patient care. Dr. Nati would first take us or walk us through the scale of hepatitis C in Ghana and on an initiative that is working to eliminate it, which is the Stop Hep C project. So, Dr. Nati, your audience.
Thank you very much, Dr. Ayi. Can you hear me and can you see my slide?
Yes, please, we can. And we can hear you clearly.
Great. So good afternoon, good evening, everyone. My name is Dr. Yvonne Nati, as I have been so kindly introduced. Today, I'm going to talk about hepatitis C in Ghana and focus a little bit on Stop Hep C. This is the outline of my presentation. I'll start with the background and natural history, progress through these bullets, and end on actions needed to achieve elimination. In terms of background, hepatitis C is a positive sense single-stranded RNA virus. It replicates in the cytoplasm of infected cells using its RNA genome. And unlike hepatitis B, hepatitis C does not integrate into the host genome directly, making it highly amenable to targeted antiviral therapy. When we look at its history, it was discovered in 1989. Various treatments were initiated, but it wasn't really until 2011 when direct-acting antiviral medications were discovered that there was a huge game changer in terms of hepatitis C management. In 2016, pan-genotypic regimens, meaning medications that span a broad range of hepatitis C genotypes, were discovered. And so important was this work that in 2020, Harvey Alter and his colleagues were awarded the Nobel Prize with regard to hepatitis C and all their work in terms of its development. So when we look at the natural history, when someone gets acute hepatitis C infection, 20% of people will recover and they will lose the RNA from their blood. About 80%, that is the majority, will have chronic hepatitis C infection and will remain RNA positive. The majority of them will be asymptomatic, about 80%. Of these, up to 20% can develop liver cirrhosis, and up to 4% can develop liver cancer. We need to be able to catch these people at the right time. When they are asymptomatic, living with hepatitis C, this is the point where if they've been infected, we need to be able to catch them. We shouldn't also forget that hepatitis C can cause extrahepatic problems. Every organ in the body, from the brain to the skin to the kidneys, can be affected by hepatitis C. And hepatitis C is known to cause a common fatigue that persons who live with it tend to experience. So what about the epidemiology? Globally, there are 47 million people in the world who are living with hepatitis C infection. And if you look on this chart, you can see that in the region of the Americas, Eastern Mediterranean, European region, the burden is going down. You see an obvious trend downwards. What about the African region? This is so much more subtle. We can barely see any decline in the number of cases of hepatitis C infection. When we look at what this means for us in Ghana, the new cases of hepatitis C are pretty high. We have a high incidence in terms of our population size. So Ghana is a country with a high burden of hepatitis C. And this is also obvious when we look at the top 20 countries where Ghana features. Unfortunately, being part of the top 20 in this setting is not a good thing for Ghana. We don't want to be here. So there are certain things we need to be able to do to be able to achieve elimination and come out of this top 20 bracket. Within the country itself, several studies have been done looking at the antibody prevalence. When we say antibody, it means the proportion of people who have been exposed to the virus. So the prevalence of those who have been exposed to the virus in a study in 2016 was put at about 3%. Another study we did in 2023 showed it was fairly similar. But worryingly, a recent systematic review by Fosu et al. Puts this figure at around 6%, meaning that approximately 460,000 persons in Ghana are living with hepatitis C. When we look at subgroups, we see that in those who have chronic liver disease, about 1 in 10% of them will test positive for hepatitis C. And very obviously, the burden is highest in the northern part of the country. And this is something that as a nation, we also need to look at, investigate, and address. So what are the modes of transmission? In a rapid review by Tantoyere et al., we found that unsterilized needles and safe medical procedures are the commonest routes of transmission. But there are several risk factors. This includes patients undergoing chronic hemodialysis, traditional scarification using unsterilized equipment, exposure to contaminated blood products, unsafe sexual practices, people who inject drugs because of the practice of needle sharing, household transmission, including sharing of personal care items, and to some degree, maternal to newborn transmission, although this occurs to a lesser extent. So what does the WHO say? Well, it says we have to reduce the number of new infections by 90%. We have to treat 80% of those living with chronic hepatitis C, and we need to reduce mortality by 65%. If we are able to achieve these goals, we are going to avert 1.5 million deaths from hepatitis C globally. So where do we stand in Ghana? Of our 460,000 people living with hepatitis C, we've diagnosed 9%. We are treating less than 1%. About 2,000 deaths per year are as a result of hepatitis C, amounting to 5 deaths per day. I'll leave you to be the judge of where we are. If we look at, again, where we are compared to the burden, with the red bar being those infected, the green bar being those diagnosed, and the blue bar being those treated, we see that there's a huge gap, and we need to be able to tackle the factors that are contributing to this gap. So what about Stop Hep C? Stop Hep C was and is a very groundbreaking and innovative approach that has begun as a result of work from multiple partners. In March 2023, Egypt committed to donating medicines to support hepatitis C treatments in Ghana. This is because of Egypt's own history with the burden of hepatitis C as one of the countries in the world with the largest burden. So the objectives of Stop Hep C were to identify and link persons living with hepatitis C to free treatment, to decentralize HCV care through the training of healthcare workers, to strengthen viral hepatitis health information and reporting, and to contribute data to guide the review of national policies for viral hepatitis elimination. There have been several implementing partners, championed, of course, by the Ministry of Health and the Ghana Health Service, professional societies, including the gastroenterologists in the country, civil society, such as the Drive for Health Foundation and Hepatitis Alliance, and international partners, such as AHPBCC, WHO Country Office, and the Coalition for Global Hepatitis Elimination, who have provided technical assistance during the implementation. And there have been bi-weekly treatment strategy meetings since 2023, led by the National Viral Hepatitis Control Program of the Ghana Health Service, started when Dr. Achusiake Kwao was the program manager. Now Dr. Adiboka leads the discussions during these meetings, as well as our international collaborators and technical partners. So what were the initial outcomes of the first phase of Stop Hep C, which started in March 2023? We received medications from the ambassador, the Egyptian ambassador in Ghana at the time, and I'm sure you can recognize some people in these pictures. That's Professor Yao Asante Euku there, and several members from the Ministry of Health. And enough medications were received to treat 1,000 patients living with hepatitis C. We found that of the 958 patients that were reported to have been put on treatment, the majority were put on treatment in northern Ghana. 86% of patients were able to complete 12 weeks of treatment, and we had a cure rate of 93%. There was also an awareness campaign to try to increase the general public's knowledge about hepatitis C, and this was sponsored by Gilead Sciences. There was education in markets, in mosques, in nursing training schools. Several animations were made, and even people on the streets were provided with information about hepatitis C. Additionally, there was hands-on training for healthcare workers, and this focused predominantly in the 5 northern regions, where over 600 healthcare workers from nurses, lab technicians, health information officers, pharmacists, and HIV coordinators were trained. And you can see Dr. Adiboka here, Dr. Salima Samoro, Dr. Achu. Everyone got on board, including gastroenterologists like Dr. Mwakudia, to train healthcare workers across the 5 northern regions. So successful and impressive was this program that the Stop Hep C was featured on the WHO website. And additionally, at the World Hepatitis Summit in 2026, Ghana was highlighted as one of the countries that is making good progress on hepatitis C treatment. Additionally, in the recently released 2026 Global Hepatitis Report, Ghana has been featured as a country that is making strides towards hepatitis C elimination. I want to just play a few sound bites for you so that you are able to listen to some of the work that has been done when it comes to Stop Hep C.
When I got to know that the Stop Hep C project was likely to start the following year, I began looking for ways to prepare my community members to benefit from this life-saving initiative. This led me to apply for grants, and luckily I won a grant which I used to screen about 3,000 community members. I told Dr. Nate about this, and then she, together with her contacts, also secured another grant from M-Pharma Ghana, which we used to do hepatitis C RNA testing for about 100 of the patients. So as the saying goes, when preparation meets opportunity, success follows. And I think this was the genesis of our success as a treatment center. So when the project finally began in 2023, we already had patients ready for treatment. Yeah, this preparation also helped us to successfully advocate for Sandema Hospital to become a Stop Hep C treatment center because though the district hospital was not initially part, I told doc, here's the case, I have 20-30 patients. Do I have to refer all these to the regional hospital or the teaching hospitals? She also discussed with the national project team about then, and then they saw the need to give it a try to use Sandema Hospital as a case study for the future decentralization of hepatitis care. And I think we did not disappoint them at all. Yes. How I enrolled.
So that was the voice of James Amuxi, who is a PA in Sandema District Hospital, sharing his experience. Now let's hear from a patient's relative.
I'm a student, and my mom is called Angmanya Evelyn. When we found out that my mom had Hep C, we were devastated because we could not afford the treatment. Thanks to the Stop Hep C project, she received free medication, although it took a while for her to receive the medication, and she is now doing well. I can now concentrate on my studies knowing that my mother is in good health. We are deeply grateful to the project team. God richly bless you all. Thank you.
Great. And I'd like to just say that these were shared with the consent of the individuals.
When I got to know.
So what about phase 2? Phase 2 being the consignment of new medications that have been received. These were received in May 2026. And again, I'm sure you can recognize our chairman for today, Dr. Franklin Asiedu-Bequin, and the Deputy Minister for Health receiving the medicines from the current Egyptian ambassador. And now in this phase, we've increased the number of treatment sites from the initial 19 to 26 case management sites, where we have included more hospitals in the northern part of the country, emphasizing that this is a non-specialist-led approach to decentralized hepatitis C treatment. We aim to increase access to free treatment, and this time around, there's been increased involvement with regional health directorates across the country. So far, since May 2026, 382 patients have been started on soft DAC, of which 11 have completed 12 weeks of treatment. And this is from reporting from 18 out of 26 facilities. We see that there's an almost 1:1 male to female ratio, and that the co-infection rate for hepatitis B and C is 3.7%, and the co-infection rate with HIV is 0.3%. We also see that the majority of reporting is coming from Upper East and Northeast regions, and again, Northern Ghana leading the way in terms of number of patients who are being initiated on treatment. We see that about 38.8% of patients being seen have an increased ALT level, meaning potentially that these are patients who without treatment could likely be in the stage of progressing because they have active hepatitis. We also see from ultrasound findings that a proportion of patients are presenting with an echogenic liver. That means that there's evidence of some changes in the liver, about 10% with cirrhosis, and about 5% we've been able to pick up the presence of liver cancer. There are obviously challenges that remain, and if we look at the phase 1 implementation challenges and how during this phase we've attempted to mitigate these, initially there had been a lot of reliance on opportunistic screening, and though that is still predominantly the case, there is some planned regional population-based screening based on funding availability. Additionally, viral load testing is one of the most difficult barriers to overcome. There has been some advocacy to reduce the price of hepatitis C viral load, and the National Public Health Reference Lab currently offers the viral load at 400 cedis. In the earlier consignment, there was medication expiry, but currently this consignment will expire in 27 and 28 respectively. There were some medication stockouts and some consignment delays, but already the national program has started to make provisions to start initiating receipt of the next phase of medications. There had been inconsistent reporting in phase 1, but this is much improved during this phase because of partnerships with the regional health directorates, and low awareness was a big problem. We see that awareness is increasing, and especially during this time, there has been a lot of engagement across several channels to increase hepatitis C and B awareness. So what next? I want to come back to this call from the WHO that we need to reduce infections by 90%, we need to treat 80% of people, we need to reduce mortality by 65%. I want to also emphasize this gap again between those living with hepatitis C, the proportion we've diagnosed and the proportion on treatment. If we are, as a country, going to achieve the WHO 2030 targets, then we need to at least diagnose 127,000 people annually between now and 2030. And we need to put 127,000 of them on treatment. How are we going to do that? Though we don't have a national population-based screening program, which I'm sure as Director General is here and he did mention the free primary healthcare approach, which might be an opportunity. Until that starts, we need to think about clinician-initiated screening, offer a hepatitis C test to any patient who walks through your door. We need to do opportunistic screening in our NCD clinics and all our other clinics. There must be pre-procedure screening. Most of the time, we will test for B and leave out C. We need to do both. The NGOs are doing a great job and we need to support them to do more screening. There has to be the drive on individual requests to do hepatitis B and C screening. And most importantly, we have to think about a population-based approach through a Know Your Hepatitis C Status campaign. Finally, family and household screening should be reflex. When we see a patient living with hepatitis C, we need to ask them, are there members in your household? Have they been tested? And one of my bosses already does this. He already has a hepatitis C kit in his office. When he sees a patient, he will now ask, you, the patient relative, have you been tested? Today, I will test you if you consent. This is an approach that we can also look at. We have to remember, though, that when we are screening, we need to use Ghana FDA-approved test kits. And the way to know whether the kits you have are FDA-approved is to go on their website and look at their product register. We also have to tackle the elephant in the room, which is hepatitis C RNA testing, because currently patients have to pay out of pocket. Some regional and teaching hospitals have the capacity, and the National Public Health Reference Lab is currently offering this test at 400 Ghana cedis. Civil society has also negotiated with some private labs, including Revna, MDS, SynLab, to name a few, who have brought down their test prices slightly. But we need to tackle this nationally so that we can increase access to RNA testing, because it's one of the major barriers to linkage to care. So if we continue our status quo, what will happen? Well, by 2030, we will not meet our targets. And in fact, we are not going to meet those targets until after 2050. So collectively, we need to champion efforts to increase all the opportunities that we have to increase the number of people who are tested and treated. If we look at Egypt's example, they went from being one of the highest burden countries in the world to now being achieving gold status, where they are have a path to elimination. When we look at what they did, there was strong political will, there were no treatment restrictions, there was a national awareness and national screening campaign, and there was financing for the program. Where do we stand as Ghana? I'll leave you to evaluate we ourselves as a country. I'd like to end with this slide by our consultant, Dr. Kenneth Tachi, who says hepatitis C virus infection in Ghana, the time for action is now. And the only word I will add is, we want it right now. That's not a word, that's a sentence. Thank you. I'm happy to take your questions.
Thank you very much, Dr. Nate, for the brilliant presentation. Indeed, the time is now. We would continue right ahead with our second presentation, and then thereafter, we would take some questions. So our second presenter is a consultant gastroenterologist and physician specialist at the Confanoche Teaching Hospital, in the person of Dr. Nyantechi Edudako, and he's going to walk us through the hospital work of diagnosis and treatment of chronic hepatitis C. Dr. Nyantechi, please, if you are ready, you may proceed.
Thank you very much, moderator. Can my slides be seen and can I be heard?
Yes, please. We can see and hear you.
Oh, okay. Dr. Nate has done all the heavy lifting, so I'll just run through this fast and then we'll just take the questions. I'll be taking us through the diagnosis and treatment of chronic hepatitis C infection. Yeah. I have no disclosures and this will be my outline. As Dr. Nate said, the main routes of transmission of hepatitis B. First, when it comes to our healthcare setting, there are healthcare practices that lead to transmission of hepatitis C, i.e. renal dialysis, surgical procedures that uses on sterilized or inadequately sterilized equipment, dental care, on-screen blood transfusions, needle stick, and injuries that affect health workers. Other modes of transmission will include people who inject drugs, so those who do IV drug use, and those who abuse drug in our system. That remains the main primary driver all over the world, and it accounts for over 23% of all new hepatitis C infection. And there's also a role for mother to child transmission. It affects about 4 to 8% of children born to women with chronic hepatitis B. And then for percutaneous exposures, it includes unregulated and unsterile procedures such as tattooing, body piercing, and then these traditional scarification. So once these practices are unregulated, there is no standard for everyone to follow, and then they end up using poorly sterilized equipment to perform their procedures. For sexual transmission, while it occurs infrequently in monogamous heterosexual couples, it's documented more frequently in men who have sex with men. The natural history of hepatitis C, after the acute infection, the virus is able to evade our immune system such that 55 to almost 90% go into chronic infection. So whilst in the chronic state, over the next 20 years, you have 20 to 24% of patients developing liver cirrhosis. And once you develop liver cirrhosis, 3% per year may end up going into a decompensated liver cirrhosis. And then 1 to 4% per year may develop hepatocellular carcinoma. Those are the things that we fear can occur when someone develops hepatitis C. And by way of clinical features, acute hepatitis C is rarely seen because most times the symptoms are asymptomatic. Those who have symptoms are so non-specific that it's difficult for them to blame it on hepatitis C. Non-specific symptoms will include fatigue, nausea, abdominal pain, loss of appetite. They may have some mild fever. Among those who come with overt symptoms of hepatitis C, 50 to 84% may come with jaundice. And there are very few reported cases of acute liver failure from chronic hepatitis C compared to other hepatotrophic virus. Most of the time, when the person goes into acute liver failure, it's more severe when the person misuses or abuses alcohol, if the person has a co-infection with hepatitis B infection and then HIV co-infection. The graph here shows how the virus and then other lab indices moves when someone catches an infection. As I said, majority asymptomatic, and then once you develop the infection, by the 7th day, you have RNA in your blood. Your ALT levels will start elevating from about the 3rd week and will reach a peak by the 3rd month. After the 3rd month, the ALT levels will decline gradually, and then once the body is able to clear the virus, it stabilizes down there. At times, if you go into chronicity, the ALT fluctuates such that it could be high, it could be low. When it comes to the antibody that is used, used to test for chronic hepatitis C, it starts increasing after the 2nd week, and then it peaks by 6th month, and then will stay that way for up to 20 weeks, so 20 years. So it means that those who are exposed to hepatitis C, irrespective of achieving cure or not, will have the antibodies present, and that one will be seen. The effect will be seen when we are testing for people with chronic hepatitis C. When the disease reaches chronicity, the ALT levels, as I said, fluctuates. However, as many as half may be normal. Most patients are asymptomatic before the onset of advanced liver fibrosis. Non-specific symptoms will include fatigue, vague abdominal pain, depression, and then it's been established that people with chronic hepatitis B have low health-related quality of life. There are some extra hepatic manifestations that have been proven to be associated with chronic hepatitis B. Some of them will include autoimmune thyroiditis, B-cell non-Hodgkin's lymphoma, lichen planus, mixed karyoglobulin, monoclonal gammopathies, and then porphyria cutaneous stata. Other conditions have been linked, but there hasn't been significant studies to confirm that they can hepatitis C led to those conditions. Those are the chronic polyarthritis and diabetes mellitus, idiopathic pulmonary fibrosis, and all the others. So it means that most times, once in your clinic, when patient presents with these conditions, hepatitis B screening must be a must for you to be sure if those conditions were from hepatitis C or not. The progression factors, there have been established factors that have been shown to increase fibrosis, the progression of fibrosis in people with hepatitis C. Established factors will include those who are aged more than 40 years, if the person is taking significant alcohol use, if the person is also having hepatitis B or HIV co-infection, if the person has immunosuppressive states, the person has insulin resistant and obesity, and then the male gender has all been established to increase the rate of progression to fibrosis. Other four possible factors that have been linked to the progression to fibrosis include marijuana use, smoking, schistosomiasis, and the white race, and then increased hepatic iron concentration. Once someone comes to the hospital, or how do we pick patients who have hepatitis C? Most of the times, there is a universal screening. Most of the time, if someone is more than 18 years at least, and there is no possible risk factor, they could be picked up either during the hospital visits or during routine screening to test for hepatitis C. There are people who are below 18 years, and if they are found to have significant activities or exposures. The exposures will include like someone on chronic dialysis, someone who is immunosuppressed, or the activities like men who sleep with men, those who are IV drug users. If they are 18 and below, they could be targeted and be tested. For perinatal care, all pregnant women should be, it's a recommendation for all pregnant women to be tested for hepatitis C. High risk group should be tested annually. So the high risk group could be people who inject IV drugs, men who sleep with men with HIV, and then men who sleep with men who are taking pre-exposure prophylaxis. These are the high risk groups who should be tested yearly for hepatitis C. By protocol, the initial testing for hepatitis C is to check first if the person has been exposed to hepatitis C before. The main test is the antibody test. The antibody test only checks for exposure. It doesn't check for whether there is a current infection. So once someone tests positive for the antibodies test, then you have to go ahead and then do the RNA testing. The WHO recommend what we call a reflex testing. For the reflex testing, patients, once the samples are taken at a go, once one sample is taken, and then the person is noticed to have hepatitis, a test positive for the antibody, then the same sample is further tested for the RNA to check if the person has an active infection or not. Most times, this one helps helps with the loss to follow-up of patient. It also helps prevent delays in linking patient with care. So if we come to our environment here, currently we are not doing the reflex testing because people are paying out of pocket for the hepatitis C screening, and they go to the lab as and when they get money. So if we want to be able to meet the WHO goals for the hepatitis C, it means that all these things, those who are having hepatitis C, who test positive, should be the reflex testing should be done to pick them early and then link them to care. There are some people who may test negative when you do the antibody test, but it doesn't mean that those people do not have hepatitis C. If you are acutely, or if you've been infected less than 6 months, or if you take a typical example, a care worker who get exposed to a contaminated blood. Most of the time, immediately you do the test, the antibody test, it may come out as negative. It doesn't mean that the person has not been infected. It means that the person is in the window period. So ideally, you may have to wait for 6 months to do the antibody test again to show if the person was exposed or not. Or you can go further immediately and then do the RNA testing. As I said earlier on, the RNA tends to start appearing by the first week of infection. There are also conditions, people on chronic dialysis. Most of the times, once you're on chronic dialysis, some of them may be immunocompromised. So once you're immunocompromised, the antibody, they're unable to produce antibodies. So such people tend to test negative to the antibody test. So once someone is on chronic dialysis, it's best you start your investigation with the RNA testing. And again, there are some people who have been exposed or who have been exposed to hepatitis C and have been treated for hepatitis C. Because hepatitis C has no vaccine, if once you get it and you are treated, there's always a chance that you may be reinfected again. So it means that such people, because they've been exposed before, the antibody test will always be positive for a long time, for up to 20 years. So such people, once you establish that the person has had prior exposure to chronic hepatitis B, there is no need doing the antibody test since it will already come out as positive. So you go straight to the RNA testing to be sure if the person has an active infection. And again, when you are counseling on results, a positive antibody test with a negative RNA results indicates no active infection. But you must advise the patients that they are not immune to reinfection, as I said. So they will have to go through all the preventive measures to help them prevent getting infected with hepatitis C. For the treatment goals, the good thing with hepatitis C is that it's curable. It's the only viral hepatotrophic disease that could be cured. So most of the times, you can achieve what we call a sustained virologic response, leading to cure. And then once the person is cured, there's why you eliminate infectivity of the person, then you improve the person's quality of life. Again, once you put the person on treatment, one of the goals is to induce regression of any existing liver fibrosis and then significantly curtail the escalating risks of end-stage liver failure and hepatocellular carcinoma. And then once all these things are done, it means that you are able to reduce both liver-related mortality and all-cause mortality across patient populations. When it comes to the treatment of hepatitis C, there has been an evolution. And initially, we had the interferon-based therapies. It had very low efficacy against the common genotypes, and then the treatment was often not curative. Then they had significant side effects. Then present day, we started developing direct active antivirals. Most of the time, the DAs are curative in 95% of patients. As the Stop Hep C data was presented, here the initial data had about 93% cure rate. These DAs have fewer side effects and then a shorter duration of treatment. Most of the DAs, the treatment is between 8 weeks to 24 weeks. The pangenotypic DAs are considered pangenotypic when they achieve high treatment efficacy across all 6 major hepatitis C genotypes. And this has led to the elimination of one of the expensive laboratory investigations we have to do before we could put people on treatment, the hepatitis C genotype. Because pangenotypic DAs are able to manage all genotypes. Right now, we've practically eliminated the extra cost of testing for hepatitis C genotype. DAs have simplified the care pathway, as I said, by removing the need of expensive genotype, and so has streamlined procurement and supply chains, and then expanded the global treatment access. Some of these pangenotypic DAs include soposbuvir, hepatitis, glecaprevir, pibrentisvir, and then soposbuvir, daclastravir. If you go through the stop hepatitis C presentation, what we are using in Ghana, or that what has been donated, is the soposbuvir, daclastravir. Patients who are 18, who are more than 18, and who are between 3 to 17 years without cirrhosis, you could put them on soposbuvir, hepatitis, and then soposbuvir, daclastravir for 12 weeks. And then if you are using the glecaprevir, pibrentisvir, that one, you can put the person on those treatment for 8 weeks. If the person has a compensated cirrhosis, most of the medication is still 12 or 8 weeks. And then at times, if you are not getting response, soposbuvir, daclastravir could be extended to 24 weeks when you are managing someone with compensated cirrhosis. So I'll go through some algorithm to help us do our pre-test monitoring and then post-treatment monitoring when we meet patients with chronic hepatitis C. Those who will follow this algorithm will be those who are being infected with chronic hepatitis C, including HIV co-infection, who has not been previously, who has not received any hepatitis C treatment, who are infected with any genotype, and then who have no cirrhosis or have compensated cirrhosis. Most of the time, the cirrhotic bit or the fibrosis can be assessed using what we call transient elastogram. Most of the time, transient elastogram is available in very few locations in Ghana. So if that one is not available, you could use the lab-based non-invasive fibrosis scores like FIB4, API score. At times, these things may not point or may not give much information, so you may want to go ahead and do a liver biopsy and allow the pathologist to go through and give you an idea of the level of fibrosis, but that one is quite rare. We hardly do it now. If a patient has a prior hepatitis C treatment history, if the person has a B co-infection, if the person has a compensated cirrhosis with low EGFR, that's EGFR below 30, if the person has a current or priorly compensated cirrhosis, or if the person is pregnant or is known or has you have suspicion of ACC, such patient, you have to manage the patient what they call in conjunction with the specialist. So you have to contact the specialist or refer to the specialist to manage these complicated cases. So if you have a patient who is treatment naive and then has no cirrhosis, pre-treatment wise, you have to assess the fibrosis state of the patient. Could use the APRI score. The APRI score uses the AST and then the platelet. You put it in a formula and then it will give you a score. And then FIB4 uses SAMAST, age, and others. You could have this scoring system on apps and online that you can input the parameters. That one helps assess the fibrosis status of the person. And then assessing the fibrosis status of the person help you to determine the duration of treatment. And again, if you have to, monitor the person for HCC after you are done treating. You have to do your baseline full blood count. You have to do a liver function test. You have to do an EGFR. Then you have to do a quantitative confirmation of hepatitis C by doing the RNA, and you have to find out if there is any co-infection with HIV or hepatitis B. One other thing that we have to always take note of is the DAS tend to interact with certain drugs that may affect the efficacy. So you may want to know the medications that the patient is on before you start. Once you know those medications, there are several apps that you can check for drug interactions. And once you find that, you may advise accordingly. Again, there's very few research done in the pregnancy world. So you have to make sure the person is not pregnant before you start, else you may have issues with maybe either teratogenesis or maybe the person losing the pregnancy. So you have to rule out pregnancy before you start this treatment. Whilst on treatment, typically there are no known routine lab that you would do to monitor the treatment. What you could do is that you have to monitor people with diabetes for hypoglycemia. Hepatitis C has an added effect of causing insulin resistance. So once the person is on treatment, and then you is on treatment, you clear the hepatitis C. Once it's being cleared, it means that the insulin sensitivity is increased. Once this thing happens, and then someone is on a standard dose of anti-diabetic medication, if you're not careful, the person may end up going into hypo. So such people, you have to monitor such people, what do you call, for hypoglycemias. Again, you also want to monitor for the INR for patients who are warfarin, because it may interfere once the liver is getting better. It may interfere with the INR of patients who are on warfarin. Since there is no routine lab monitoring for such patients, most of the times you can do telemedicine to monitor the patient to ascertain their issues. So you can either do it by phone call or by online, call patient, find out how they are doing and all, and then wait for the 3 months duration. So post-treatment, once you are done with the treatment for 12 weeks, you have to wait for another 12 weeks to check what we call SVR12. Most of the times, once you do the SVR12 and then the viral load is undetected, it means that you have achieved cure. So once you've achieved cure, it means that there is no need to follow up such patients who are treatment naive with no cirrhosis. But again, you also have to re-emphasize the counseling on the need to stop taking alcohol, then the need to go through things that will help that person from, getting reinfected, since there is no vaccine available for chronic hepatitis, for hepatitis C. For patients who are not cured, after this treatment, you may have to refer to specialists for them to, continue treatment for such patients. If you have a treatment naive patient with cirrhosis, such patients who are compensated, so it means that those who are in Child-Pugh A, as part of your pre-treatment workup, you have to calculate the Child-Pugh score to confirm that they are compensated states. You need a liver ultrasound to confirm the cirrhosis. You do the baseline full blood count, INR, LFT, you check the AGFR, and then you may want to confirm the hepatitis C RNA, confirm if there is any co-infection with HIV, Hep B, and then be sure that the person is not pregnant by doing a pregnancy test. So whilst on treatment, you have to monitor for any liver injury. There are rare cases of hepatic decompensation for people who are on DAS, so you have to monitor. And as per for those who have no cirrhosis, if the person is diabetic, because of the initial explanation that hepatitis C can cause some amount of insulin resistance, once you clear them, the insulin sensitivity improves. So if the person is on the stand or on his normal medication, it may tip the person into hypo. So you may want to monitor the person for hypoglycemia. Once you are done with your treatment, you have to confirm the virologic cure by doing the SVR12, as explained earlier. But this patient, because they have a significant fibrosis or they develop cirrhosis, after achieving cure, they still have some risk of developing HCC. So you would have to do what we call hepatocellular cancer surveillance. You do 6-monthly ultrasound and alpha fetoprotein to do the hepatocellular carcinoma surveillance. Again, such patients, you may want to evaluate the person for viruses and then advise the person to abstain from alcohol. For the management for unique groups, most of them, if you have HIV and then hepatitis C co-infection, HIV is no co-infection as a tend to make the patient worse. The rate of progression to fibrosis is increased, and then the outcomes are worse. Such patients can still follow the initial algorithm I mentioned. So you could use that same simplified algorithm to treat them. If someone has acute hepatitis C infection, as I said, most people, you have to treat you should treat the person the same way you treat a chronic hepatitis C infection. You don't wait for any possible spontaneous clearance, because maybe within that time the person may end up developing some significant fibrosis that may end up costing the person in future. So once you diagnose someone with hepatitis C, whether it's acute or not, you have to treat immediately. For pregnancy, you have to consider the treatment on case-by-case basis. While large-scale trials are pending, smaller studies have shown no significant concerns. But because we haven't done large-scale studies, you have to treat it on case-by-case study. For hepatitis C in children, the current guidelines recommend treating all hepatitis C infected children and adolescent age with approved who are more than 3 years with the regimens as I described earlier. After treating this patient, as I said, you always have to help re-emphasize the need to prevent hepatitis C since it has no cure. So most of the times, healthcare and blood safety, and there has to be blood screening. So testing 100% of donated blood for hepatitis B and C, as is being done in our environment. And then there has to be a safe injection. So you have to use sterile single-use needles and syringes for medical care. So this goes to maybe some health facilities who may have issues with their consumables and then other procurement issues. We have to make sure all the equipment being used, especially needles and syringes, single use, and then they are always disposed of before someone gets to use it again. For universal precautions, you have to follow strict infection control and waste disposal in hospitals. At the community level and then lifestyle prevention, you have to do what I call harm reduction. So by harm reduction, you have to provide sterile needles and low dead space syringes for people who inject drugs. Yeah, though those who abuse or IV drug users are breaking the law and things. If you talk to the NGOs, once that thing is there, you may have to find ways of helping reduce the transmission of hepatitis C among that group. And we have some NGOs who go around donating or distributing sterile needles and syringes to these people, so that even if they continue doing their illegality and all those things, it will be safer for them and reduce the risk of contracting hepatitis C. You have to ensure proper sterilization of tattoo, body piercing, and then traditional skin piercing tools. One thing I've noticed is that right now people are actually doing tattoos anyhow in their backyard, in rooms. You see people advertising for tattoos in their own backyard. I don't know the safety practices that has gone on or the regulations among this group, but they have to be properly regulated so that they reduce the risk of transmission of hepatitis C. For personal items, you have to avoid sharing of razors, toothbrushes, or sharp personal items that may carry traces of blood. So take-home message in all this: hepatitis C is curable infection. The paradigm of care has fundamentally shifted through universal screening and early diagnosis. Using the hepatitis C RNA confirmation, we can identify patients swiftly. So prompt treatment with highly effective pangenotypic DAs paired with appropriate post-treatment follow-up successfully prevents cirrhosis, liver cancer, and death, while dramatically restoring quality of life. Thank you very much. These are my references.
Thank you very much, Dr. Nantu T. Edudako, for brilliant presentation and taking us through the diagnosis and management of chronic hepatitis C in the clinic. We'll invite our program director, Dr. Adiboka, to give us a few words, after which we'll have a presentation by one of our sponsors, Mega Life Sciences, and then we'll take our questions.
Thank you very much for the opportunity. Two excellent presentations. So for my presentation, I think it's just an overview of what we've been doing since the beginning of this month. It's not really a presentation, just to let people know what we've been doing up to today. So I'm just going to take you through at the beginning of the month up to the 28th, what we plan to do, what we have been able to do. Of course, we need everybody on board. So what we did this year from the beginning of July up to now was that we decided to have national activities and then regional activities across the whole country. So on the Monday 6th to Friday 10th, what we did was that we started having radio and TV engagement to create awareness on viral hepatitis B and C. And then the same thing was encouraged on all the district and the regional hospitals to also do the same. Then the following week, we continue with radio and TV. As I know, we've been able to go around all the major radio and TV stations. We've been to Metro TV, we've been to TV3, we've been to Joy News, we've been to UTV TV. I don't think there's major TV station with not creating awareness. And then on the 19th, of which we did last week, so the 19th, we did it on the 18th because of a webinar that was supposed to come on the 19th to GMA webinar. As we said, as we're doing right now, we collaborated with Gaslit to have a webinar on overview of viral hepatitis B in Ghana, and then hepatitis B in pregnancy and the management. And I hope all those who joined the meeting that day had a very good education on it. And to also continue to do screening, what we have decided was that we cannot screen all the people across the whole hospitals. So we decided to carry out a screening in the headquarters. So on the 21st of this month, we had a screening at the Public Health Division in Kolibu. So we screened all the staff. Most of the staff came. And on the 22nd, we also went to Pantine, the headquarters Ghana Health Service, to screen. And on the 24th, we did on the 23rd, we did a screening at the Tema Station. That's one of our headquarters offices. And then on the 24th, which was on Friday, I had the opportunity to be with the Hepatitis Alliance, and who had Professor Kosi, who had a screening done at Danfa. It was a lovely screening there. I got there, and then I was able to go there with Ochiame Kwame. It was a lovely screening. And then we also included, there were some other district hospitals that had the opportunity to carry out some screening. And then on the 26th of, that is today, the webinar we're having is what we plan, and it is happening now, which is the Stop Hep C, and then project that we're doing in Ghana to let people know that we have free medications across all the regional and teaching hospitals and some selected district hospitals. And then we have just had a very excellent presentation on the Hep C diagnosis and management, of which we are happy. The D-Day that we are having will be on the 28th of July. That is next week, Tuesday. What we intend to do is to have the commemoration of the World Hepatitis B, World Hepatitis Day at the Ministry of Health. The minister will be there. The Director General will be there. Director of Public Health will be there. Our chairman will be the Dolewura NIB boss. We're having press briefing, and then we'll be launching a very important group called the Viral Hepatitis Technical Working Group. Because we need a big brains that can come together so that we can sit down and look at how we can eliminate viral hepatitis by 2030. You cannot do that alone. So this group is going to involve academicians, researchers, excellent gastroenterologists, and other food and drugs board, other agencies we think they can help us to carry this mantle. And there are other hospitals and other district and regional hospitals and district health directory that are going to do screening across. In Accra, the Accra Regional Health Directory will be doing one at Kaneshi. So you can join them and add across the whole country. So it's not something that is happening within only the Ministry of Health, as the program is going to happen there. We're trying to even create a link so that tomorrow, on Tuesday, those of you who will not be there, you can join us online. And we want to make sure that all the stakeholders are involved because of some of the policies that are coming up that we can do that. And then for the on Wednesday on 29, what we want to do is that the screening that is ongoing, we want to collect the data. You can't screen people and leave them. And now what we want to do is that after you are screening the people, you link them to care. Otherwise, it's cost 90. If you go to market, screen people, tell them that they have B, have C positive, and ask them to go home. What is the benefit? So we want to make sure that anyone who is being screened is linked to care. We have a register, they report to us, get their numbers, even if you cannot. Because right now, all our HIV coordinators across all the regions are part of us. We can link them, the doctors, we can link them to all the doctors across the region. And what we are now coming out is that we want to come out with a registry for viral hepatitis, so that even if you are tested in the northern region and you enter into the register, if you are tested in the Kumasi or whatever you enter, then anytime we need the data, anytime we need to link people to care, we can call you. That is what we want to do. And after that, after the World Hepatitis Day, we don't want to end it there. So we have a series of planning. And one of the things I want to do is to continue training. So we want to embark on training across the whole country. So we do it region by region. Because we know that for treating viral hepatitis B and C, it's not bad, only the gastroenterologists. You can refer every patient to Kolibu Teaching Hospital, Confornot Teaching Hospital, Tamale Teaching Hospital. It's difficult. Some people are at the village, they can't go. And because of that, people cannot access care. We have now access to care. So what we want to do, we want to embark on training people on how to treat. So whichever district, whichever region you are, you can, even health centers, we can train you how to treat this disease and link up to the necessary people to help. And then with that one, we'll be able to come out with algorithms. And the good thing we are coming out as a technical working group is to develop guidelines. We're updating the guidelines soon, and that guidelines would be shared among all the hospitals, the regional teaching hospitals, even health centers. So, and then they will be able to use that one to do the treatment. So we are encouraging everybody, try to encourage people. We are coming out with so many policies. There's the Hep B dose, the triple elimination, which involve the HIV, Hep B, and syphilis also coming up. And then I know Director General and then Minister of Health, they are coming out with other policies as the primary health care is also coming up to see how best we can enroll everybody on board to do general screening. So for now, we call on everybody to support us on the 20th. If and after that, we continue to fight together. Thank you very much.
Thank you, Dr. Adiboka. Yep. So if we can have the presentation by Mega, and then afterwards we would run through the questions.
Good evening to everyone. My name is Renee Afo. I'm a product executive
So
with
Renee, you
Mega
may please
Life
go ahead
Sciences.
after.
Hello, can you hear me?
Yes, please, you may go ahead.
Okay, a warm evening to everyone. My name is Renee Afo. I'm a product executive with Mega Life Sciences. Mega Life Sciences is a pharmaceutical company into manufacturing, distribution, and marketing of pharmaceuticals. Mega Life Sciences has manufacturing sites in Thailand and in Australia. And these two manufacturing sites supply medicines to over 35 countries globally. Mega Life Sciences, beyond just marketing of medicines, is looking at committing itself to improving public health through meaningful corporate social responsibility initiatives. And that is why in the past, Mega Life Sciences has collaborated with associations like Gaslit on World Hepatitis Day in order to raise awareness and advance the collective effort to eliminate viral hepatitis. And for this year, we are actively collaborating with the National Viral Hepatitis Control Program on SAME. And for this reason, we want to introduce to you our Livolin Fort, which is our 3-in-1 hepatoprotector containing essential phospholipids, specifically our phosphatidylcholine, vitamin B complexes, and vitamin E for better regeneration of the liver cell membrane, for protective and restorative functions of the liver, and also to help decrease the release of liver enzymes. Livolin Fort is beneficial for all types of liver disorders, of which viral hepatitis is one of them. And what Livolin Fort does is that it helps to supplement the liver with essential phospholipids, which are lost or degraded as a result of these liver disorders. The dose for Livolin Fort is 1 to 2 capsules 3 times daily. Then moving on to Limza. Limza is our combination brand of enteric-coated omeprazole 20 mg and domperidone sustained release 30 mg capsule, indicated for all your acid reflux diseases, inclusive of GERD, NED, gas, and dyspepsia. The dose for Limza is 1 capsule daily, which makes it more patient-friendly and adherent. Then we go on to Avarin, which is our Avarin citrate 60 mg combination, which is our antispasmodic agent, and Simeticone 300 mg, which is our anti-flatulence agent, indicated for your irritable bowel syndrome, for your peptic ulcers, for your diverticular diseases, for your dysmenorrhea, and other intestinal conditions. The dose for Avarin is 1 capsule 3 times daily. And finally, we have our Nomagat, which is our probiotic, our freeze-dried yeast of Saccharomyces boulardii 250 mg, indicated for your acute and chronic diarrheas. Nomagat does not just stop diarrhea, but it also helps to normalize the gut's flora. The dose for Nomagat for children 2 months to 2 years is 1 capsule daily, and for children 2 years to 12 years is 1 capsule 1 to 2 times daily. And for children, you twist open the capsule shell and you dissolve the contents with either water or juice of the child, and you ensure that the solution is taken completely by the child. And for children 12 years and above, as well as adults, the dose for Nomagat is 1 capsule twice daily. Thank you all very much.
Thank you for the presentation, Renee. And so we'll go straight to our questions. Thank you all for staying on even up until this time. We have about 14 questions in our Q&A. Some of these have already been answered by our resource persons. And so we'll go straight ahead and start with the questions. So, Dr. Nati, one Vidanati is asking for us to highlight more on hepatitis C in pregnancy, especially because it is case specific, and if there are any exact modalities of management, and also how is the baby managed post-delivery. And this question is similar to another one concerning pregnancy concerning hepatitis C and pregnancy. And so I'm hoping that it can also be fully addressed. I think the other question that's related to this talks about how hepatitis C testing can be incorporated into routine laboratory testing for pregnant women.
Okay, I don't know if I should take it or Dr. Nyantechi since he mentioned it, but I can start and maybe Dr. Nyantechi can continue. So just in terms of pregnancy, actually globally, there are no definitive guidelines that I'm aware of that speaks to hepatitis C in pregnancy, but there are local or national or regional practices. Some clinicians will treat hepatitis C positive pregnant women from the 2nd or 3rd trimester, and actively there's evidence being collected to look at safety. There isn't much reported in terms of adverse birth events. So there are some schools of thought that will say it's safe to treat from the second or third trimester. Others will say wait until after delivery because the treatment is not an emergency. With regard to babies, the current guidelines will say that we wait until the infant or the child is 3 years. I don't believe that there are currently guidelines for treatment of children or children under the age of 3. But again, my senior colleagues can chip in there. But from age 3, it's still the DAAs at a dose that is specific for the weight of the child, and SOFDAC can be used in a weight-based regimen. Yes, thank you.
When it comes to pregnancy, as Dr. Nati already said, there is not much large-scale studies for hepatitis C in pregnancy. So most of the time, we try to err on the side of caution. So for mothers who are infected with hepatitis C, the general rule is that you wait till they deliver before you consider putting them on treatments, since it's not an emergency. And when it comes to the perinatal period, the risk of transmitting hepatitis C during the delivery process is around 4 to 5%. And if the person has HIV co-infection, then the risk increases. So most of the time, the normal vaginal delivery will suffice. There have been some small study that has shown that doing CS for a woman with hepatitis C doesn't reduce the risk of transmission. The only reduction that was seen was those who had co-infection with HIV. So most of the time, it's this normal, basic, routine things that we do during delivery process to prevent infection that we do for people with mothers with chronic hepatitis, with hepatitis C. Again, the virus too doesn't have though it's found in the you could have some in your breast milk. There are not a lot. So unless there is evidence that maybe there are cracked nipples that will lead to maybe some amount of blood being mixed with breast milk, the teaching is that the mothers will continue breastfeeding normally as they would do with someone if they didn't have hepatitis C. So those are the main things when it comes to pregnancy and then hepatitis C.
Thank you very much, Drs. Nantichi and Nati. So Samuel Trine is asking, what does it mean for hepatitis C antibody test to be equivocal, and what should be done? And his second question is, where can we get the direct acting antivirals for treatment?
So the test is reported as reactive, non-reactive, or positive or negative, the antibody test. In terms of where you can get treatment, all regional hospitals, all district hospitals, and selected district hospitals in northern Ghana have the medication available. If I just list them right now, just so that you hear them. In Upper East, it's the Bolgatanga Regional Hospital, Sandeman District Hospital, War Memorial Hospital. In Upper West, it is War Regional Hospital, War Municipal, Jirapa District Hospital. In Northern Region, it's Tamale Teaching Hospital, Yendi Municipal Hospital. In Savannah, it's Bole Municipal, Central Gonja Hospital, Salaga District Hospital. In Northeast, it's Wale Wale Hospital, Nalerigu Baptist Medical Center. In Bono, it's the Sunyani Regional Hospital. In Bono East, it's Holy Family Hospital, Techiman. Ahafo is Goso. Ashanti is Komfuanoche Teaching Hospital. Volta is Ho Teaching Hospital. Oti is Rara Hospital. Eastern is Eastern Regional Hospital, Koforidua. Western is Ifian Kwanta. Western North is Sefirio. So Central is Cape Coast Teaching Hospital. Greater Accra is Kolebu, Ridge Hospital, and the University of Ghana Medical Center.
When it comes to the equivocal test, there are studies actually that are trying to link the time it took for the test case to be positive with whether there is RNA or not. There are studies that say that if the test turns positive within 5 minutes, it's very likely that there is RNA present. For the equivocal bit, one, it could be that it's false positive. It could also be that the person has an early infection within the window period that they don't have a lot of what do you call these antibodies for the test to determine accurately. That's why once this happens, the person has to be retested, or you have to go further and do the RNA test to be sure. And again, you should also remember that there could be lab errors. Lab errors could be the reason why it's not equivocal. So you take all those things in consideration before you do it.
Thank you very much for the answer. So, Japheth Ofori, I think your question has been addressed as Dr. Nati went through the various centers. And if there are still any worries, you may just please reach out concerning that. So Isaac Wassa is asking for himself working in the Upper East, a border town. They have a lot of foreigners who are testing positive to hepatitis C. Are these individuals also eligible for the treatment as being rolled out by the Stop Hep C project?
I think program manager can take that one.
Yes, please. Dr. Adiboka, any comments on this, please?
Yeah, so that's a very complex question. You know, most of the people around the body, they enter into Ghana to seek health. So it becomes difficult and some of them are intermarried. Some they stay even Burkina Faso. Some people move there, come. So it depends. For now, if the person is living in Ghana and the person has the right, the Ghana card, it means the person is a Ghanaian. The person is entitled to treatment. So the person has to go through the right process, get identified, get to the treatment site, either Bolga, if it is in Upper East, either Bolga Regional Hospital, War Memorial, Sandema, for the medication.
Okay, then. Thank you. And so we have another question from an anonymous attendee who speaks about a 20-year-old who has been newly diagnosed with hepatitis B, with who is asymptomatic, and LFTs came out with no derangement. This person is asking if treatment must begin regardless. So doctors, Nati, doctors.
So it's a hepatitis B positive 20-year-old who has what, normal ALT?
Yes, looks like normal LFTs. This person is asking whether treatment should be started regardless.
Okay, so for hepatitis B, I think last week we mentioned the indications for treatment for hepatitis B, but just broadly, we need to take a good history from this person. We need to know if there's a family history of anything like liver cancer, liver cirrhosis, liver failure, etc. We also need to know whether there are any comorbidities or anything that can lead to immunosuppression. Is the person on long-term steroids? Do they have an additional autoimmune condition, etc.? Then we can now look at the person's physical examination, etc., and then the labs. Generally, if we do the patient's APRI score, if it is more than 0.5, it could indicate that the person has potential fibrosis, and regardless of their viral load or their ALT level, then they may require treatment. Alternatively, if the patient has an ALT above the upper limit of normal and a viral load of more than 2,000, they qualify for treatment. If they have a comorbidity that shows evidence or that could potentially lead to hepatic impairment, such as fatty liver from diabetes, dyslipidemia, etc., or they have co-infection with HIV or hepatitis C, or if they've done a hepatitis D Delta test and it's also positive, then they could be put on treatment. If they have immunosuppression from any cause, be it HIV, autoimmune disease, malignancy, they are on long-term steroids, regardless of their viral load or their liver function test, they need to be put on treatment. Alternatively, if they have persistently elevated ALT in the absence of a viral load, they would need treatment. If this person is female and gets pregnant and they do the E antigen and it's positive, or they have a viral load that is more than 200,000, they may need to be put on tenofovir prophylaxis to prevent mother-to-child transmission. And as I've mentioned, if there's a family history of liver cancer or liver cirrhosis or liver failure, regardless of the viral load, etc., they should be put on treatment. That's just a summary. I don't know if I've missed anything.
Thank you, Dr. Nati, for that. I think it's comprehensive enough. Lawrence Champon wants to know if we have any plan for the prisoners in Ghana, especially because they are incarcerated, and if there can be any elaboration on this for healthcare teams in the prisons. And the other question I would add is concerning feedback. Philip Bonfa is asking about how various facilities and various individuals, when they refer for care, can receive feedback on the outcomes of their patients who they may have referred for hepatitis C care.
So with prison inmates, it's a very good point that has been raised, and studies that have been done in prisons have shown that there is a higher burden of hepatitis B and a marginally higher burden of hepatitis C in the prison settings for inmates. For the prison officers, hepatitis B prevalence is comparable to the general population, but hepatitis C prevalence is surprisingly slightly higher. There have been some small-scale prison projects by civil society groups such as the Hepatitis Foundation of Ghana. I think Ochiame Kwame in the past has also done something, and various other groups, even including the NECP, to strengthen hepatitis B testing, vaccination, and linkage to care. But it has not been done on a national scale in terms of all the prisons, and there is a gap there that needs to be filled. There are limitations in the prison setting because the inmates have to pay out of pocket, as the general population does, for their viral load testing and for treatment of hepatitis B. There is the potential for access to free treatment of hepatitis C only if these inmates end up being referred. I'm sure program manager will speak to the fact that the national program intends to engage the prison service to be able to see how we can strengthen hepatitis B and C related services within the setting, including leveraging on existing HIV service delivery platforms to train the ART program officers within the prison setting so that we can link to care. However, funding is needed to be able to strengthen this, and I'm sure the program is exploring how best they can do this.
Thank you very much for the response, Dr. Nati. We have a comment in this Q&A that talks about individuals who test positive for hepatitis B and C being denied food vending certification. And they would want us to throw some light on that, whether this should be the case and what our recommendations could be in that light. And also, if we can have the list of the various facilities in the various regions that individuals can either send their patients to or report for care, so that it's easier for various people to refer to whenever they need to send their patients for the needed care.
I think program manager can take the one about the food vendors.
Yes, please, Dr. Adibuka.
Yeah, so in terms of stigma, the food vendors that is what we are talking about, the stigma that we have in Ghana. People who have been tested positive for Hep B, Hep C, they are being denied into denied so many opportunities, either being employed, either being able to travel, and some of them have been asked to go and treat the hepatitis B and come back. We all know that if you put you on treatment for Hep B onto I don't want to use the word that kingdom come, but it's a long-term treatment. So it may deny the person that opportunity. We know that for Hep B, there's no transmission through kissing, through eating of food, through it's not a foodborne disease. It's blood to blood. So there shouldn't be any opportunity or any reason you should deny someone from given a job because the person has Hep B. So for all food vendors and people who go around to give certificate to food vendors and saying that because you are positive for Hep B or Hep C, you can't be given certificate. I urge them to stop that. And then we are still embarking on all this awareness creation to let people know that this is not the way to go. For Hep C, we said it's three months and then you are being killed. So that doesn't mean that you should stop. And if you're not blood, it's not through food. So we just need to educate the people, encourage all the health workers who are going around educating people to let them know that touching people, eating food, shaking hands, all those things will not let someone get Hep B or Hep C. So all this is just because of lack of awareness. And it's usually sometimes our health workers are the people we need to talk to educate the people. Thank you.
Thank you very much, Dr. Adibuka.
Hi, moderator. Thank you.
Yeah.
If I can come in here, Dr. Dria
Yes,
here. And I think we have to address this issue once and for all. For me, I think those who give the certificate, are they not under Ghana Health Service? If they are under Ghana Health Service, then we need to issue either a statement or letting them know that Hep B, Hep C is not transmitted through food, so that they stop harassing the food vendors and stop letting people lose their job. Because there are so many people that work in restaurants that are losing their job. And you know how the economic situation in this country is. So I think PM, you can take it up. And from today onwards, let's tell the health people in the district and assemblies to cease testing them for, if they want to screen them for it so that they can link them to care, that is good. But for the purposes of issuing certificate for them to sell food, I think from today onwards, let's work on it so that this one doesn't keep up. I'm very happy that the director, Ghana Health Services here, and then also Dr. Franklin is also here. Let's work on it so that we stop this food vendors being harassed because of Hep B and Hep C. Thank you very much.
Dr. Dear, thank you very much for emphasizing on this point. So most of the people on this platform, we have some regional health directors, and then some across the whole country. I think as we be embarking on training and engaging people, we need to talk to the public health nurses and then maybe those involved in screening people so that those kind of certificates will stop. And director is also around. I think we have to make sure that this information is being taken into the district and then the community level.
thank you very much for all the contributions. I think that we've done justice to today's topics, and I would call on Dr. Asiedu Bekwing to please give us his closing remarks, after which we would continue with the vote of thanks. There may still be questions that may have been unanswered. You may please reach out via email, and we would be able to. We are also answering these questions also as panelists. So you may please refer and to the answers appropriately. Chairman, please, over to you. Hello, Dr. Asiedu Bekwing. Okay. Seems that we'll try to see if we are able to reach.
Yes, boss.
Dr. Asiedu Bekwing, please, your closing remarks for this session.
Don't worry, I'll take it for the two of us. Okay.
Yeah.
Yeah. So that he doesn't talk and then later we say, Director General, people are tired. It's been 3 hours. Let me just say that I've listened throughout last week and this week. Last week, unfortunately, towards the end, I was driving and I couldn't come in for a final word. But today, fortunately, I've been able to listen to everything. And I must say thanks so much to the audience. At the point, we got to over 500 people online. And we still have over 400 people online. And that by itself is very encouraging. And the lectures were quite excellent. So let me express my gratitude to those who made the presentation. I know what it takes to make a presentation. You sacrifice the whole day, the whole month working on this, and it's paying off. The organizer, once again, thank you. And it's paying off simply because this is how policy is done. The agenda setting is by the people who actually have the knowledge. So right now, I've already set up some few things when it comes to the food vendors and other issues surrounding pregnant women, people, cross-border issues. Let me just say that the local government, the hygiene and the epidemiological unit, they also have a role to play when it comes to the food vendors. So we all come together and then we come out with a policy per advice of those who are technical and they have the know-how. It's not just going to be one of those guidelines made by anyone. So I just want to say thank you so very much to each one of you. And we look forward to see how best we can roll out this from our schools, community, to all the way to our clinics. And as I said before, and I'll repeat again, will be that the free primary healthcare will do its best to integrate this. We'll look very seriously into issues of vaccines, issues of test kits, issues of medications, and how best those can be made as affordable as possible to anyone, towards anyone who acquires, whether B or C. Anything that we can do will be in the mood to get that done, because that is what we should be doing to make sure that we have a healthy population for a healthy country that would increase productivity and all that. So, hello? Hello?
Yes, please, Director, we can hear you.
So I've been heard, right?
Yes,
Oh, I
please.
was off.
I think at the latter part, it just muted off, but
All right. Okay. So that's fine then. Thank you.
Yes, thank you so much for joining us and for your comments. We are grateful. Madam President of the Ghana Association for the Study of Liver Diseases, would you please have any words for us? Otherwise, we'll move on and have our closing remarks. So, Dr. Micah, please, if you have any words.
Good evening.
Good evening.
We are very happy that we had our distinguished Director General of the Ghana Health Service and Dr. Esiebi Bekwintu online. Last week we had them, but we couldn't let them talk. So I'll say that I purposely decided that one of them should be a chairman today, so that we'll be able to get the maximum benefit. And it's been 2 weeks talking about hepatitis B, hepatitis C. And it's good that currently we are looking at decentralizing treatment, because it's very disheartening when people come and they've gotten to the latter stages. Because someone tested and they were hepatitis B positive, but they look at the profile and they tell them that no, you don't need treatment, you can go home and relax. Only for them to come back 4 or 5 years later with hepatocellular carcinoma. So it's good that currently we are looking at decentralizing treatment so that everybody who needs treatment will be able to afford it. The other one too is integrating hepatitis care into a national health insurance, just as it was done for renal dialysis, which is more expensive than hepatitis treatment. I think that it should be done for hepatitis as well. I always tell people that everything concerning hepatitis is paid upfront. From the initial testing to the viral load to the treatment, everything is paid upfront. And it will be very disheartening when someone has to cough up 300 cedis every month for tenofovir. And you see the person, you know the person's salary, and you realize that that person can't afford, but they still have to manage to do it. So if we can get the treatment on national health insurance, it will be good for us so that we'll be able to treat everybody. It's been done for hepatitis C. Thanks so much for all the efforts, including the Egyptian government. It should be done, even though for hepatitis C, you have to be able to do the viral load and other things. If you are able to get that money to do it, then the treatment is free. But I think that we should look at the labs also, integrating all of them under the national health insurance so that a lot of people can benefit. It's only when people are given treatment that will be able to reduce the hepatitis burden in our country, and then we'll be able to achieve the WHO target for 2030. Thank you very much, and we are grateful for all who attended both online webinars. Thanks so much. Over.
Thank you very much, Madam President, for your words. Indeed, let's all rally behind to eliminate hepatitis, viral hepatitis by 2030 as WHO proposes. We'll invite Dr. Emmanuel Amankwa to give us the vote of thanks.
Good evening, everyone. So I would like to start by thanking the program manager, Dr. Adiboka, and his team for putting this together. Appreciation also goes to our chairman for today, Dr. Franklin Esiedu-Bekwin, and the Director General, Dr. Kaba Korea, for making time to be here with us today. Thanks to our presenters, Dr. Yvonne Nati and Dr. Kwejunian Tichi, for the excellent updates in hepatitis C epidemiology, diagnosis, and treatment. We also want to thank Mega Life for always being available to support us. To everyone who was able to make it a point to be here today, we say thank you. And finally, all thanks to God Almighty for making this program a success. Let's not forget that the time for action against hepatitis is right now. Thank you.
Thank you, Dr. Amankwa. We'll have Dr. Owusu Setre give us the closing prayer.
Good evening, everyone. Let us pray. Our Heavenly Father, we thank you for the knowledge we've received today. Help us to use it wisely to protect our health and care for others. Bless everyone affected by hepatitis with healing and strength, and guide us to make healthy choices. Keep us safe as we go from here. In Jesus' name, amen.
Amen. And thank you all once again for being part of this. Hopefully the recordings will be shared with us so that the slides as well as indicated would also be shared as appropriate. Thank you and have a good evening.
Thank you too. Bye.